Like Mark said, I did my PhD at Queen's and I finished it 2 years ago. And my PhD really focused on the epidemiology of physical activity and sedentary behaviour. And then since then, I've been working as a postdoc at the University of Bern. But I've kind of changed fields so that I'm really focusing on infectious disease epidemiology and specifically COVID. So all my projects have been related to COVID in this role. And I've looked at things like contact tracing data, and I've been involved in a review for the WHO looking at outcomes for children with COVID. But most of my time has been spent looking at living evidence and specifically conducting a living systematic review about COVID and then looking at the methodology behind that and producing a practical guide on how to keep a living systematic review alive, really. So that's what I'm going to speak to you about today. And I think it's relevant for everyone working in science or public health, whether you're actually producing the original research or you're synthesizing evidence or simply reading a report that's to understand how the evidence was synthesized. So hopefully there'll be something for everyone. So first of all, I'm going to talk about how evidence evolved during the COVID-19 pandemic, and then specifically how living systematic reviews became more popular, and then our experience of conducting a living systematic review on COVID, and then how we put together what we learned to create a practical guide. So first of all, the evolution of evidence on COVID. Before I started working here, the team at ISBM, the Institute of Social and Preventive Medicine at Bern, started this living database of evidence on COVID-19. And this was a simple web application. It was open access and it's available at that link there. And it searched PubMed, Embase, bioRxiv, medRxiv, and PsycInfo every day, looking for, using search terms like this, looking for articles on SARS-CoV-2 or COVID-19. And it collated them all in one database so that you could search, and this is how it works. You enter your query here, and then you get your results. The green highlighted articles are peer-reviewed articles, and the red highlighted articles are preprints, so they haven't been peer-reviewed. So you can find results that are relevant to your search or what you're interested in, and then download them as a CSV file or an RIS file. And I think when the team started this project, they had done something similar for Zika virus, and I don't think they expected to find so many articles on COVID. So by March 2022, we had over 300,000 publications in this database. And so this graph just shows the cumulative records over that time. And the team at the time did a comparison on articles they found during the Zika virus outbreak and then during the COVID outbreak. And as you can see in this figure on the right, the scales are very different. So these Zika virus articles all fit within that small grey dash box above for the COVID period. So it was really a lot more than I imagine that they expected. And even this graph shows the new monthly records in the database. And even over time, the number of records continued to increase. And although at face value, this seems like a positive thing at a time when we really needed to understand what was happening with this new virus and new disease, it seemed like a positive thing that so many people were working on it. But on the other hand, the pandemic exposed some weaknesses in how we produce research-based evidence. And this report, How COVID Broke the Evidence Pipeline, was published in Nature in 2021. And it highlighted the problems specifically in clinical trials on COVID. So they looked at a database, and there were 2,900 COVID trials by, I think, around May 2021. And there were several issues with these trials. For example, here, this figure shows that 40% stated that they were enrolling fewer than 100 patients. So the results weren't necessarily very useful with such a small sample. And many research teams were working on the same questions. For example, there were 250 trials on hydroxychloroquine. So there was a lot of duplication going on, which wasn't ideal. It represents a lot of research waste. The Wellcome Trust, and I think they anticipated how important it was that research data and findings were shared as much as possible. And they released this press statement in January 2020 saying that they called on researchers, journals and funders to ensure that research findings and data relevant to this outbreak are shared rapidly and openly. And in practice, this means sharing preprints of your work before peer review and publishing in open access journals. And hopefully that would avoid, hopefully that doing that makes people aware of what you're working on and avoids things like research waste. So there are many benefits to sharing work in a preprint before it's released as a published peer-reviewed article, as well as just making people aware of what exactly you're working on. It's really helpful to get some results shared as quickly as possible. And I think this is a really nice example. This is work done by the Recovery study that was set up in the UK. It was set up very quickly in response to COVID, looking at treatments for hospitalised patients with COVID. And in June 2020, they released their preliminary findings that dexamethasone was an effective treatment against COVID-19. So they released this in a preprint on June the 22nd, and 3.5 weeks later, it was published in the New England Journal of Medicine on July the 17th, 2020. And if you're familiar with publishing, you'll realize that that's actually very, very fast. So I'm sure it was fast-tracked, but I think even 3.5 weeks could have made a big difference at that point in time, because there are so few options for patients with COVID. So I think it's in situations like this, it's especially important to get the results out as quickly as possible. But of course, on the other hand, lack of peer review can be problematic. And there was an example of a flawed preprint that was released in ivermectin, which fueled some fake news about its effectiveness. And there were people in countries around the world who were using ivermectin against COVID when that wasn't appropriate. So there seemed to be something going on. Scientists were obviously under a lot of pressure to find solutions to find treatment against COVID and to understand what was happening. And it seems likely that they were under pressure to publish things that might not have been the highest quality. And this is reflected in a report that was released in 2021 that showed that COVID articles were actually being retracted at a higher rate than articles on other diseases, as you can see in this table on the right. And Retraction Watch is a nice way to keep up to date on which articles are being retracted. It keeps a database of all articles that have been retracted. So as well as people working in science, I think as well as having a responsibility to conduct good quality research, we also have to be careful when we publish our work that we're citing from reliable sources. And this, on the left here, this is site reference check, which is a bot on Twitter which detects papers that have cited a paper that's already been retracted at time of publication. So, for example, they highlight that this paper in PLOS 1 cited this paper from the Journal of Cellular Physiology, and it had already been retracted at the time the PLOS 1 article was published. So I think that's something we can easily try to avoid. So to sum up how evidence evolved on COVID, there was really a very high volume of evidence on COVID-19, and the pandemic helped to expose problems in how we generate research-based evidence. And open science is one way where we can make information more accessible and hopefully avoid research waste, but there are disadvantages that we have to be aware of. So moving on to living evidence, I'm specifically talking about living systematic reviews here. And they're defined as continually updated, incorporating relevant new evidence as it becomes available. And it's not a new methodology, but it's a new approach to review updating. And it involves making a commitment beforehand of how often you're going to update the living systematic review. And this definition came from a series of papers in the Journal of Clinical Epidemiology released in 2017. And it has some really helpful guidance on what a living systematic review is and how to conduct them, and statistical issues to be aware of. And a living systematic review is actually a massive undertaking, so it should only be considered in specific circumstances. And that's when the topic is a high priority, certainty in the existing evidence is low, and that there's likely to be new evidence to come out that might change the existing conclusions. And during the COVID pandemic, topics on COVID met all of these criteria usually. So I've just added the graph here that I've shown you before, showing how many articles were coming out in COVID. So there was always a possibility that findings had to be reviewed and findings would change over time. So we see a rise of living evidence and living systematic reviews during the pandemic. And this is just a search that I did yesterday for living systematic review in Web of Science. And as you can see, as soon as we get to the COVID pandemic in 2020, the number of results shoots up. So these are some examples of living systematic reviews on COVID. Another team at ISBM in Bern looked at the impact of the pandemic on mental health. And the BMJ published a living systematic review on drug treatments for COVID-19, which also involved a network meta-analysis. And another living systematic review looked at risk factors and outcomes in pregnancy, outcomes of COVID in pregnancy. So that brings me to our living systematic review. So this was started before I began working at the University of Bern in early 2020. And I believe it came about because the Federal Office of Public Health in Switzerland asked my supervisor, Professor Nicola Lowe, to provide an answer to this question: what proportion of people do not have any symptoms? And then it's turned into this project, a large living systematic review. So this is the most recent published version of the review in PLOS Medicine. And these are the questions that we were asking. First of all, among people who become infected with SARS-CoV-2, what proportion does not experience symptoms at all during their infection? And we specifically wanted to know who experienced the infection without any symptoms at all throughout the entire course of their infection, and not just whether or not they had symptoms at time of testing. And also the infectiousness of asymptomatic and pre-symptomatic compared with symptomatic infection. So asymptomatic without any symptoms at all, and pre-symptomatic were people who initially did not have symptoms but went on to develop symptoms. And finally, what proportion of transmission is accounted for by people who are asymptomatic or pre-symptomatic. And this is the timeline of how the review progressed. So there were 3 updates in 2021. These dates here refer to the search dates. So the first version found 89 studies, then 230 studies, then 688 studies. And these were manageable amounts to deal with. But after the 3rd version, the team were actually overwhelmed with the number of articles to screen. And that's why there's a long gap between the 3rd and the 4th version. And then the most up-to-date results were in version 5 with a and these were the results. So there were 130 studies included until July 2021. And it's important to note that this is before the time when variants of concern came out. So these studies included 28,500 people with SARS-CoV-2 infection, and just under 12,000 of those were asymptomatic. And we found that the results seem to systematically differ by study design. So we grouped together contact and outbreak investigations, and that was usually when one person was positive with the virus, and afterwards everyone in the workplace or the vicinity or the cruise ship was tested to investigate how the spread of the virus. And also screening studies, which were studies that had tested everyone in a workplace or an institute like a nursing home or just in a community, and that had also followed people up for their symptoms after testing. And what we found was the studies had so much variability and there was so much heterogeneity that it wasn't actually appropriate to generate a pooled estimate, and that's why we haven't provided one here. So we present a prediction interval, which is an estimate of the interval that a future estimate would fall in based on the previous estimates observed. And as you can see, they're very wide as there's so much variability between these studies. The results for question 2 were a bit clearer. So we were looking at the secondary attack rate from asymptomatic and pre-symptomatic cases. And we expected that asymptomatic people would be less infectious than symptomatic people. And that's what the results reflected. So asymptomatic people had a relative risk of 0.32 of infecting someone else compared to a symptomatic person. And when we compared symptomatic and pre-symptomatic infections, they had an equal chance of infecting someone else. And finally, we included mathematical models which looked at that reported the proportion of transmission from asymptomatic or pre-symptomatic infections. And again, here we thought that these mathematical models had so much variability between them that it wasn't appropriate to pool the results, so we simply present them here in a forest plot. But as you can see, just looking at the results, it appears that the asymptomatic transmission results, the proportion of transmission from asymptomatic people generally seems to be lower than the proportion of pre-symptomatic transmission. So our conclusions from this study were that based on studies published up to July 2021, we believe that most SARS-CoV-2 infections were not persistently asymptomatic, and asymptomatic infections were less infectious than symptomatic infections. And I think after the fourth update, we expected that if we include more studies and find more appropriate studies to synthesize, that we would have a clear result, but actually the opposite happened, and more studies led to increased heterogeneity. And summary estimates from meta-analyses may be misleading when the variability between studies is extreme, and that's why we present prediction intervals. So where are we now? The epidemiological landscape has changed considerably since we started this review. We have new variants, and the figure on the left shows a screenshot from the covariance website, which is very useful when you're looking at variants. It takes publicly available sequencing data from all around the world and looks at the proportion that comes from different variants. And so these different colours represent different variants becoming dominant in Switzerland over time. And at the minute, of course, we're solidly in an Omicron wave. As well as that, immunity has changed a lot because of the vaccines that are available and previous infection. So what we're working on now is looking at the proportion of asymptomatic infection in variants of concern only, and also extracting information on vaccine history and previous infection history, and also making the inclusion criteria stricter so that we are hopefully reducing the selection bias, which we believe might have influenced the results in previous versions. So, in other words, we're only including people who were tested regardless of symptom status, so that didn't play a role in whether or not they were tested. And after conducting this review and finding a way to deal with keeping it alive and trying to keep the review alive was very difficult during the pandemic, and we thought that we could use what we have learned, and hopefully it would be helpful to other reviewers working on living systematic reviews, specifically looking at observational evidence, and specifically in a pandemic situation where there's a lot of evidence coming out quickly. So therefore, we've created this guide, and first of all, we looked at the state of living evidence on COVID-19. And to do that, I just searched the WHO COVID-19 database using the search term living systematic review to look at living systematic reviews on COVID. And I found 97 unique living systematic reviews on COVID. And I wanted to look at their characteristics to see how other people had conducted living systematic reviews on COVID. The most popular topics of these reviews were pharmacological interventions that looked at treatment, for example, or prevalence of conditions or risk factors. For example, our review looked at the prevalence of asymptomatic infection and also diagnostic test accuracy. And we also recorded which types of studies did the living systematic reviews include. And most had included observational and randomized study designs. And we think this is interesting to look at because perhaps part of the reason why we were so overwhelmed by the number of studies to include was because we were specifically looking at observational research. And whereas randomized controlled trials have to adhere to strict reporting guidelines. So when you're searching for randomized controlled trials, you can simply filter by randomized controlled trials and find studies that are closer to what you want. And then when you're extracting, generally the information that you want is easier to find because they have to adhere to these reporting guidelines. Whereas there's a lot more variability in how observational studies are reported. And then we wanted to look at how often these living systematic reviews were actually updated, because the guidelines that came out in 2017 said that living systematic reviews should be updated at least once every 6 months. But in reality, we found that really difficult, and we wanted to see how other teams found that. And it seems like other teams have also struggled to actually achieve that. So here I have grouped studies by the first date of publication. So in the first half of 2020, 78% of living systematic reviews were updated. And then afterwards, this proportion decreases quite a lot. So clearly it's difficult to keep a living systematic review alive. So therefore, we looked at the whole process and thought about what we did and what others did to make it more efficient. So this gives an overview of how to conduct a living systematic review. First, you establish the review, then set up a research team to work on it, and then follow the normal steps of conducting a systematic review. And then importantly, once you get to the point when you publish the results, you have to decide whether to end the living systematic review or review the protocol and start the entire cycle again. So this was the original team that was working on our living systematic review in 2020, and it grew to include many more people. So when you're setting up a review team to work on a living systematic review, it's important to make sure there's sufficient expertise in the team, not just subject area and expertise in evidence synthesis, but also if you're conducting a living systematic review, you might want to consider having at least 1 or 2 people in the team that have some programming skills, because then it makes it more possible to automate certain steps in the process. And we use crowdsourcing. That's why we have such a large team. So when the team got overwhelmed in 2020 with the amount of work they had to do, they reached out to their networks, people who had some epidemiology qualification and experience in systematic reviews, and asked if they would be willing to volunteer some time to screen articles and help with data extraction and risk of bias. And especially if you're considering crowdsourcing, it's really important to define the criteria for authorship. So exactly how much work is one person expected to do to qualify as an author? And because living systematic reviews can go on for a long time, it's important to decide what to do if an author leaves the team. Perhaps they can be moved to the acknowledgements to acknowledge their previous contribution to the review. When publishing a protocol is always important in a systematic review, but there are specific considerations when conducting a living systematic review. Specifically, it's useful to say how often you intend to update the review, and declare the conditions in which you'll stop updating the review, and consider that the scope of a systematic review, of a living systematic review, can become narrower over time because of course, as the epidemiological landscape changes and the evidence changes, it might be appropriate to change your protocol, but the scope can only become narrower without having to conduct a whole new search. And when searching for studies, there are certain ways to make that process a little bit more efficient. So first of all, automatic alerts are available in many search databases. And we find that database aggregators are really useful for living systematic reviews. So for example, the database that I mentioned at the start, that was a database aggregator because it brought results together from different databases. And there are also other database aggregators for COVID-19 specifically, like the Cochrane COVID-19 Study Register and the WHO COVID-19 Research Database. And like I said, if you have the expertise to program in your team, you can consider conducting automatic searches, which saves a lot of time. So that's what we did. We programmed an automatic search that would take results that mentioned asymptomatic or pre-symptomatic in the title or abstract from COAP, the COVID Open Access project that we created, and automatically save them to an electronic database. So that happened once a week, and we didn't have to worry about the search and spend time on it. And the next step is to consider how you would like to screen the studies and collect the data and organize the data. We screened our studies in customized R Shiny apps. Again, to create that, you need some experience with R. And we saved our data in REDCap, which is a customizable electronic database where you can securely store your records. But other platforms are, for example, EpiReviewer and Covidence, which can be used to screen. And that's really useful, especially if you have a large team. It's really helpful to have all of their decisions stored. Another thing to consider are semi-automated machine learning tools, which we didn't use because we didn't feel like they were appropriate for the studies we were searching for. And also, this is something really in development. So these tools are very new. But in certain reviews, they might be really helpful. So that should be something to consider. And then once you get to the point of publishing a review, because this is quite a new approach to updating, currently the journals are doing different things to deal with this new approach. So we published in PLOS Medicine. And in our 5 updates, there were 2 peer-reviewed published papers in PLOS Medicine, these 2 here, and the other 3 updates stayed as they remained as preprints. But these updates were judged to be different enough that we didn't just update it, we actually published a new article with a new DOI. And as you can see, it indicates in the title of the second publication here that it was an update. But the BMJ, for example, has a different approach. This is the Living Systematic Review on Drug Treatments for COVID. And you have to go to related content on the BMJ website, and then you can see that there were previous updates of this article reported, but they all have the same DOI and the same webpage. And finally, you have to decide when to stop a living systematic review. So, and this should be something you think about at the very beginning. So there should be some condition. For example, it can be a specific date or a specific month, or when you think that the new evidence is unlikely to emerge and change your findings, or it can be simply when the publishers say so, or when the available funding runs out. In the BMJ, they state that after 2 years, they will review the need for continuation. And for our review, we decided that when the estimates were stable and unlikely to change, or the question is no longer of importance at that point, we would stop the review. So those are some of our guidance on how to conduct a living systematic review. So to sum up, we think you have to be realistic about the time and resources that you have available, because it really takes a lot of time to set this up and to run the whole workflow efficiently. At the very beginning, plan when to end the review, and consider crowdsourcing time-intensive tasks that maybe don't require experts to do. And if possible, automate the searches to save yourself a lot of time. And consider machine learning tools, which are, I believe in the next few years, could become much more popular in systematic reviews. And then finally, think about how you're going to make your results available so that people can access them. So publish preprints and then in open access journals. Okay, so these are my take-home messages. I think that evidence synthesis is really time-consuming, as I've spent most of the last 2 years doing it, but it's really worthwhile to generate high-quality evidence. And open science principles can improve the evidence generation. I think they're really important for the people generating original research, because they can be aware of what other teams are working on, and it can open opportunities up for collaboration. But it's also really important for people like myself who are synthesizing evidence so that we can actually access all of the evidence that's out there. But on the other hand, there are drawbacks that we have to be aware of. And I think that now is really the time to think about how we generate evidence before the next epidemic or pandemic comes along, hopefully not for a long time. So thank you very much for your attention. I'd like to acknowledge my supervisor, Professor Nicola Lowe, and my colleagues Diana and Mert, who really have been heavily involved in this work. And of course, the crowd of volunteers, without whom we would not have finished this review. Thank you very much, and I'm happy to take any questions.